She is now professor of nutrition and associate dean for research in the College of Education, Health, and Human Sciences. She is the author of more than 125 journal articles, and she has been funded in the millions of dollars by the National Institutes of Health, American Diabetes Association, the Academy of Nutrition, and Dietetics Foundation, and also Weight Watchers International, among many others. So thank you very much, Hollie Raynor, talking to us today about childhood obesity.
Well, thank you very much for the introduction, as well as for the invitation to be able to share some of the work that I do. I'm going to go ahead and see if I can share my screen. And can everybody see that?
Yes, looks good.
Okay, excellent. Thank you. Thank you for that feedback. So one of the areas that I work in from a research perspective is this idea of translating what we do in research into actual practice. So that's what I'm going to focus on. I'm just going to start with a little bit of an overview of what evidence-based practice is, and then describe the translational challenges that we have from research to practice. And then give you a few examples that we've been doing over the past almost 15 years now to help with translation. And then end with an example of a grant that I partnered on with Cherokee Health Systems and talk through what that looked like. So first, for those of us who actually are involved in the healthcare fields, one of the things that's very, very common across all healthcare fields is this concept of the use of evidence-based practice. The Institute of Medicine recommended the use of evidence-based practice in healthcare starting in 2001. And what evidence-based practice is, it's focused on implementing current knowledge, with that knowledge being the research base, into common care decisions to improve health outcomes for patients in which we're delivering care to. Now, the way that this process works is that to be able to engage in evidence-based practice, healthcare providers actually need to be able to have a good understanding of the research base in which they work in. But there are challenges for most healthcare providers in engaging in that process. And the challenges really are about access and time. So the access issue is that many healthcare providers don't have access to the research-based literature. So unless a healthcare provider is affiliated with a large university like UT or a medical school, they just don't have access to be able to look in the literature to make conclusions about the research area. And so then if you can't look at all the literature, the conclusion that you may draw may be biased because it's only on a certain amount of the literature. The other area for healthcare providers that make evidence-based practice a bit more challenging is that it takes quite a bit of time actually to be very knowledgeable from a research perspective about and being able to assess the quality and the quantity of research in your area. And most healthcare providers just don't have the time to be able to look at the literature in that way. So because of that, most professional organizations in areas in which they're focused in healthcare develop evidence-based guidelines to help practitioners with evidence-based practice. And in 2011, because this is so now commonly done in healthcare fields, the Institute of Medicine actually developed a methodology for the development of evidence-based guidelines. It's very systematic. And most organizations that now develop evidence-based guidelines follow this process. The process includes an overall review of the literature, and then a panel then usually looks at that literature and develops a recommendation. But in that process, they grade the evidence, and the evidence is graded on things such as the quality of the research, the quantity of the research, and the consistency of the research. And then the recommendation is also graded in terms of helping a healthcare provider to understand, is there a sound research base given the recommendation? So what this looks like in practice is that a practitioner, a healthcare provider then, when they're talking about options, let's say like intervention options, the area that I work in, it's often dietary interventions. When they're talking to clients about options in regards to treatment, that the provider would actually provide the evidence base so that they would let individuals know a certain recommendation may have a strong rating, which would indicate that if that was chosen, the likelihood of having a specific outcome was pretty high, or could obviously have a very low grading, which would mean that there's not enough evidence that suggests that that's an efficacious strategy. So a provider would provide this information to inform the clients that they're working with, and then the clients then will combine that information along with their own values and preferences for their life, and then make an informed decision about what their intervention should be with that healthcare provider. Now the question though becomes, from a research perspective, is how well does the research that we actually use to develop the evidence-based guidelines, how well does that actually translate into practice-based settings? So how well can this recommendation be picked up in a hospital? How well can this recommendation be picked up in primary care, et cetera? And the issue with this translation really focuses on two types of trials. These are broad types of trials that are done in human research, which focus on determining efficacy and effectiveness. So I'm just gonna go over what that looks like so that you can sort of see a little bit of the conundrum that we have in the field. So efficacy trials are those trials that are designed to really determine cause and effect, so that we feel comfortable with that making a statement about the causation between the intervention and the healthcare outcome. So what that means is that the research then is designed really under what we consider to be ideal conditions, because we're trying to put into place a high degree of internal validity. So what we're trying to do is we're trying to design the trial so that we can eliminate all other variables that may influence the health outcome, so that we feel comfortable saying, yes, my intervention that I put into place is the reason why that health outcome changed. So what that means is that we do things like have a lot of eligibility and ineligibility criteria for participants. So for example, we want to make sure that people might not have certain health conditions that might interfere with us being able to understand the relationship. We also usually do these types of trials in research-based settings so that we have control over when the intervention can be delivered. We don't have to compete with other resources such as space, et cetera. We also usually put them in place with research-trained personnel, so that the personnel, really their only job is focused on the research trial and delivering the intervention, so they have a high degree of training in regards to what they're doing. They're not having to think about interacting on multiple health areas, for example, in a day. These are the types of trials right now that really inform our evidence-based guidelines. Unfortunately, the challenge is we just don't know how well these types of trials generalize to lots of different things, and that's where effectiveness trials come into play. So effectiveness trials are looking at what is the degree of beneficial effect under a real world setting. So we're looking at a high degree of external rather than internal validity, and we're trying to see how well that generalization occurs. So we want to know in these types of trials, how well does this intervention get implemented in lots of different settings? How well does this intervention, can it be put into place by lots of different providers with lots of different training and backgrounds. And how well can this intervention target lots of different individuals so that it doesn't matter potentially or understanding issues like race and ethnicity and socioeconomic status, how that might influence outcomes. So the challenge with both of these types of trials is that we're trying to balance what we call fidelity and acceptability from a research perspective. So once the guidelines are developed, and if they're developed with efficacy trials, for the grading to maintain its strength, that means that we have to have a high degree of fidelity of putting into place the intervention. So as the fidelity degrades, maybe we're having to change the dosage of the intervention where we can't have as much contact. Maybe we've got different types of providers that have different training. Then we know actually that the intervention probably will not have the effect that the grading has. But on the other hand, we also need whatever that intervention is to be acceptable. So we do have to have providers and consumers feel like that the intervention can be done in their setting, that they can do it in their everyday life, etc. So the translation component is a challenge because we've developed guidelines in efficacy trials, but in practice, it really is going to look like effectiveness issues. So what I want to do is just sort of show what this looks like in the area of childhood obesity treatment, and then some of the things that we've been working on to try to help with this. So I'm going to start with showing you the evidence on guidelines that have been developed from the United States Preventative Services Task Force in the area of childhood obesity treatment. So their last guideline, they reviewed the literature in 2017. And in the literature, they were looking at what we call multi-component interventions, which are interventions that have a dietary component, a physical activity or sedentary behavior component, and then a family-based behavioral, usually parenting component, which is the strategy that is used to help with supporting the change in a child's eating and activity behaviors. So they reviewed the literature for this type of intervention, and they wanted to see, do these interventions for children and adolescents that are embedded in primary care or to which primary care providers refer, are they basically, can they improve weight status in children? So the review looked at literature that had been conducted with children between the ages of 2 to 18 years who were at or above the 85th percentile body mass index, which is the classification we use for children to put them as being diagnosed with overweight or obesity, or at least 50% of the sample had to meet that criteria, with 80% of the sample having another risk factor for overweight or obesity, which is commonly having a parent or that also has overweight or obesity. And what that literature found, this is the end result of the systematic review and the meta-analysis. So this top part of the figure, what they did is they divided up the interventions by contact time. So these were interventions that had at least 52 hours of contact time in the intervention. So that generally is intervention that's provided to families in which families are getting weekly contact for a year and getting about an hour of time. And you can see from the forest plot that the effect is very good, so that these types of interventions help with improving child's weight status. And then the next category of studies are a little bit less intensive in terms of contact time. And so these are studies that had 26 to 51 hours of contact time. And again, when you look at the overall effect of these interventions, you can still see that they produce favorable outcomes by improving child's weight status. But then what happens when we get to interventions that have less contact time, we begin to see that the intervention does not have the effect that is desired. And this, while it's a lower, it's the variability is such that this is not considered to be effective. So with this review of the literature, the United States Preventative Services Task Force recommended this type of intervention be delivered to children as young as the age of 2, but that the contact time needed to be at least 26 hours. The challenge is, for many healthcare settings, that amount of contact is not feasible. It's not feasible for the setting. Insurance may not cover it. It may not be feasible for the family. So this type of intervention that's recommended is now known that we can only implement it in specialty care clinics. So that would be like the equivalent of a clinic in East Tennessee Children's Hospital. The challenge with that is that it doesn't really help us really address the health of the nation, and certainly does not help us with addressing health disparities. So while we have this recommendation, we realize that it's not going to have a big effect in terms of improving the population's health. So in the area of childhood obesity intervention, there have been proposed ways that that interventions could be developed that would help them be able to be delivered in clinics that were not just specialty clinics. And these were the recommendations that came out about 10 years ago, which is really about reducing treatment intensity. So of course, the first one is reducing contact time, which the United States Preventative Services Task Force indicates may be a bit problematic, but it also includes things like narrowing the agent of change. So in childhood obesity interventions, we generally provide the intervention to an adult that's living in the household, so an adult caregiver, as well as the child. So narrowing the agent of change would be something like just focusing the intervention on the adult rather than including the child. You could also focus on decreasing the comprehensiveness of dietary goals. So most intensive programs have very comprehensive dietary goals. So this would focus on changing the overall aspect of the diet. So this might include things like prescriptions regarding macronutrient content, fat, carbohydrate, protein, as well as energy, as well as other things. But you're changing, in a sense, all the food choices that a child is making. A less comprehensive approach would be just to target specific areas of the diet that may be problematic. And so one common way that's conceptualized in childhood obesity is just focusing on problematic food groups. So for example, sugar-sweetened beverages is a common approach. Or maybe you just focus on like snacking, so reducing the amount of snacking between meals. Also, rather than focusing on changing diet and activity or screen time or sedentary time, the focus could be on just targeting one of those. And then finally, the final recommendation was to reduce the number of the behavioral strategies that are put into place. In our multi-component programs, we use a whole arsenal of different behavioral parenting strategies, easily probably up to 20 different strategies. But the idea would be, could we identify those that we feel like are most important or most effective? And rather than trying to provide a family all 20, could we potentially provide them with 3 or 4 and still have some good outcomes? So those were the thoughts that were developed. And this sort of procedure of scaling things down, especially for a primary care setting, was actually suggested back in 2007 in a type of intervention that's called Prevention Plus. That is a low intensity intervention where there's less frequent contact, less dietary targets, less behavioral strategies, etc. Now, one of the things that's always important with translation and thinking about improving the health of the population is that it's not just relevant to find statistical significance in a intervention. What we really, really, really want to ascertain is clinical significance. In the area of weight management, the reason why we actually impact on weight is usually because that weight is a pathway to cardiometabolic diseases. And so the idea for all weight management programs is that we are wanting to produce enough improvements in weight status so that we can improve cardiometabolic health of the individuals that are receiving the intervention. So with adults, we actually know what the degree of weight change needs to occur in which we see these cardiometabolic improvements. So when we think about translation, we actually know we need a program that can do X in terms of weight to be able to see an outcome. And that X for adults is 3 to 5% weight loss. So improvements in cardiometabolic health for children and adults is not believed that a person has to lose large amounts of weight or achieve a healthy weight status, but there just needs to be a slight reduction. The challenge with kids is we just don't have enough data yet to know exactly what is the improvement in weight status that we need to see that improvement in cardiometabolic health. So it becomes harder for us to evaluate, in a sense, our translation. We have some suggestions on what that might look like. More research needs to be done in this area, but at this point in time, the literature suggests that we need to see at least a reduction of 0.13 in standardized body mass index in kids to see that improvement in cardiometabolic health. We use standardized BMI in kids in research mostly because what happens to kids as they're growing, because of the growth charts, they actually don't grow in a linear way or anything like that. So we have to, across ages and sex. So we have to standardize when we've got samples that are of different age groups and different sex, that we've got to standardize it so that we can be able to compare across studies. So with that background, I just want to show you a few examples of our trying to address some of these issues and move the field forward to improve population health. So the first study that I'm just going to talk about, I actually started quite a long while ago, but this was my first attempt as a researcher to try to help with this translation issue. So what I'm going to present on are 2 trials that we conducted that were focusing on addressing some of these things that we think that are important in translation. So we only focused on the parent in terms of making changes. It's a lower contact time, less dietary structure, and depending on the trial, there was either a focus on diet only and then another trial focused on diet and activity. In the 2 trials, there are 3 conditions in each trial. In each trial, 2 of those conditions are what we consider to be active interventions, and they actually had 2 behavioral targets, which I'll show you what they were. The structure of all the active interventions was identical. So the total contact time over a 6-month period, because the intervention was 6 months long, was 6 hours. We provided 8 45-minute face-to-face sessions to the parents over a 6-month period. We only provided the intervention to the parent. But we did maintain a lot of the research, sort of the internal validity components. This was conducted in a research setting by research staff. But we also reduced the number of behavioral strategies in this. We actually focused on the behavioral strategies of self-monitoring, which is where the kids were tracking their progress on different goals. We had them use different picture-based diaries so that they could color and draw and mark things out. We also focused on what's called stimulus control, where the parents actively worked on changing the home environment to help support the changes in their child's eating and activity behaviors. And then we also spent a lot of time on positive reinforcement. So helping parents understand how to positively reinforce the changes in behaviors that their children were going through. For the first trial, we had, this was only a diet-focused trial, but we had 101 kids. The kids were between the ages of 4 to 10, and that they were all at or above the 85th percentile BMI. And in this first trial, our 2 active arms, what we were looking at is it better to focus on decreasing energy dense, non-nutrient dense, or what many people think of as junk food. So, you know, like cookies and candy and that kind of stuff, and sugar sweetened beverages. So would it be better to do that? Or would it be better to increase healthy foods in the diet? So would it be better to focus on increasing fruits and vegetables and low-fat dairy, with the idea that if you could get kids to eat more of these healthy foods, that would push other problematic foods out of the diet? So that was one of the trials. The second trial looked at a diet and an activity choice. This trial, we had 81 kids, same age, 4 to 10, at or above the 85th percentile body mass index. And so one of the active interventions focused on decreasing sugar sweetened beverages, and then also, though, increasing physical activity to meet recommendations. And the comparison active intervention focused on the substitutes of these behaviors. So focus on having kids drink low fat or skim milk, with the idea that hopefully if they're drinking that they won't be drinking Coke. And then also to reduce their TV watching time, with the idea of if they're watching less TV, hopefully they're reallocating some of that time to going outside and playing and being active. So here's the outcome of those trials. What we basically found was a significant reduction in ZBMI in our active interventions at 6 months. The best performing intervention was our traditional, what we call traditional, which was the sugar sweetened beverage and the physical activity intervention. But the challenge was our reduction in ZBMI at the end of the intervention was only 0.12. So this didn't look like that it would, if we were interested in improving cardiometabolic health, it didn't look like that it would have enough intensity in the intervention to be able to do that. So the next step that I moved towards, by this time, I had formed a relationship with Cherokee Health Systems, which I'll tell you about, but I had a better understanding of what their practice setting was like and what would be feasible within their practice setting. And so we definitely started to test different components of Prevention Plus that I mentioned had been recommended earlier, to see how well this would perform in terms of changes in ZBMI. So this is work that one of my doctoral students did. And so what she focused on was testing Prevention Plus. We wanted to increase the intensity where we would get better outcomes than we did in the previous trials that I discussed. So the idea is that we still kept contact time low. You can see we had a monthly contact with 1 month being face-to-face and then the next month being phone. We knew that this could translate well into Cherokee Health Systems setting. It was parent focused, so the intervention was predominantly delivered to the parent. But what we did to enhance the intensity is we actually added more behavioral targets. So we had the sugar sweetened beverage and we had the physical activity, but we also added in fruit and vegetable intake and then the TV viewing time to see if more of those behaviors could overall impact energy balance better than just 2 behaviors. Again, there was the focus on self-monitoring as well as stimulus control, the home environment again, and positive reinforcement in the parenting aspect. This was still delivered in a research setting by research trained staff. And what she found, this was a very small sample, again, kids between the ages of 4 to 10 at or above the 85th percentile BMI. This condition right here is the active intervention that was tested. So there was a significant reduction. There were only, let's see, I think there are only about like 23, 24 kids as a whole in her dissertation. But the reduction in ZBMI in this active intervention here was at 0.16. So we were like, okay, that's a good size of reduction in ZBMI that should improve cardiometabolic health. So let's see if we can roll this out into a practice-based setting and see if it can be delivered in that setting and what kind of effect it will have. And so that's my final translation example, which is a total translation. So this was a grant. We started this grant in 2016, I believe. This was a NIH-funded grant where we partnered with Cherokee Health Systems. And we wanted to see how well the program that I just mentioned being tested, how well did that impact weight outcomes in underserved families. So Cherokee Health System provides integrated primary care to the underserved, and the underserved are individuals that are usually have low resources. And one of those resources is health insurance. So many families in Cherokee Health Systems do not have health insurance. But the focus of this overall project was that we wanted to see basically in their clientele, so with that kids between the ages of 4 to 10 that had overweight or obesity, so when implemented in a practice-based setting by real healthcare providers, how would this program do? Could the organization actually get it in place, and would it have an impact on their populations, the clients that they provide, their health? A secondary focus that we wanted to do was in the area of research in healthcare. We actually now focus a lot on what we call precision medicine. And the idea with precision medicine is that the same intervention is not going to work for everyone, and we have to have a better understanding of which interventions work for which individuals. And so with my work with Cherokee Health Systems, I knew that food insecurity was very, very high. We had collected some data from families one summer with the food insecure rates being close to 40%, which is incredibly high. And so we wanted then to test, was food insecurity potentially a moderator of outcomes? And we wanted to test two different interventions. One that was exactly what I have talked about previously, and then the other where we actually removed the adult in the household also changing their eating and their activity behaviors, because we knew in food insecure households, it may be challenging for multiple people to change their diet because of lack of food access. So for those of you who don't know Cherokee Health Systems, they're a federally qualified health center. They have 24 clinics in about 13 counties in East Tennessee. They provide integrated primary care to about 70,000 people in East Tennessee. So they're a pretty large healthcare organization. I have an incredibly long-standing relationship with them. I've just got some of their leadership team here. I started this partnership with them when I first came to UT in 2007. I now do engaged teaching, engaged research, and engaged service with Cherokee Health Systems. My predominant partner is Perinda Khatri, who's pictured at the bottom. She's their chief clinical officer, and just a super, super great partner to work with. So what we did in our project is this was really a multi-level intervention. So we were actually intervening on Cherokee Health Systems itself. We altered their electronic health record to be able to identify families and so that the providers could deliver the intervention, and we trained the healthcare providers on what the intervention was. Then the healthcare providers worked with the parents and delivered the intervention to change parenting behaviors and then potentially parenting, eating, and activity, depending on which group they were randomized to, with ultimately that having an effect on the child's dietary and intake and physical activity, and then their weight status. So whenever you do these kind of partnerships, it's really important to have roles established so everybody knows what they're doing. And by the time we implemented this grant, I had such a long relationship with Cherokee, and we had done multiple different types of work before. It was honestly incredibly easy. But my role was to do the research component, so to do the IRB stuff and the paperwork and the grantsmanship. We developed intervention materials with their input, which they reviewed. We worked with their IT team to alter their electronic health record. again, as I mentioned before, we provided training, we did workshops for the providers. And then after that, it's really the research team's responsibility to monitor how well something goes into place and then to evaluate it by collecting data. And then my role is also to disseminate outcomes. So I'm the person that's responsible for doing presentations and papers in which Cherokee is a partner, so they're also authors on that in that process. Their role is obviously to assist with intervention development and then to implement the program. So use their electronic health record, identify families, put the intervention in place, track it in their electronic health record, deliver the intervention in a manner that is relevant to their healthcare practice. The program was implemented in 5 of their clinics, which I've got listed there. And then they also monitored how things were going on via their electronic health record. They have a super great electronic health record, so they can pull data at any time and look to see how things are going. And how we worked on this, obviously the families would come into Cherokee, they'd be identified by the electronic health record, a provider would talk to the family about the program. If a family was interested, they signed release forms. Then we could contact the family for the research component. So we would do the consent and assent, and we would start to collect data. Once we were done with that initial assessment, we would turn the family back over to Cherokee and the behavioral health consultants, which were the providers that delivered the intervention. They would deliver the intervention and document it. And then we would do contact the family at 6 months. And then we also did a follow-up at 9 months to collect the data. This just gives you a quick overview of the intervention, but of the 2 interventions, but it specifically shows you that one of the programs, the caregiver also was changing their diet and activity. And in the other intervention, they were not. And that was really the only difference between the 2 interventions. This is our first published paper. I know that this is a little bit hard to read, but this is actually looking at how well did the program reach the clients that were eligible for the program within Cherokee's healthcare system. So we were able to track with their electronic health record what happened in the research process. So this first box, which you can't see when I go into the background, but the very first top box on the right-hand side, that talks about how many children had appointments in the clinic that were eligible based upon their age and their BMI percentile. And during the time frame that we were recruiting families, close to 2,000 families were eligible for the program. From there, about half of those families, a healthcare provider was able to meet with the family and tell them about the program. So part of the challenge with that is obviously clinic flow. So providers can't meet with every single family as they're just coming in. And so we lose a good portion of families in that process, which will be something that we'll be working on in the future in terms of our research. Then from there, you can sort of see how families sort of fell through the process. About a third of the families who met with the provider were interested in meeting with us. And then ultimately we got 73 families randomized into the trial. So that's not a high amount of reach. It's not uncommon, but part of the way that we lose families is also some families are just not interested in doing research. But again, we have this stopgap up at the top, which we will need to address in the future. In terms of our actual overall outcomes, this is just showing change in ZBMI. This is our program. The orange line is the program in which the adults were also making changes in their eating and activity, and the blue line is not. During the active intervention, both interventions did equally well, and there was a reduction in ZBMI. The kids we were working with were about, on average, 8 years old. About half of them were female. About 80% were Hispanic, and about a third of the families were food insecure. We did not see an effect of food insecurity in terms of the outcomes at all. So it was just more of an effect of time. And then we are starting to see some differences in the follow-up in terms of the programs. But the challenging part is during the active intervention, we only got a reduction of 0.09 ZBMI. So it's not a strong enough intervention to improve cardiometabolic outcomes. This shows you the changes in the diet that we saw in terms of energy intake. We saw basically a reduction of about 120 calories per day in the kids, which translate out well to the changes in weight that we saw. So in conclusion, what we have found in this process is that we can get reduced intensity interventions into real life settings, in real life healthcare settings, and that the intervention can be delivered with a high degree of fidelity. So all the data that we have show that Cherokee Health Systems did a super great job in implementing the program. But as a whole, we still need to figure out a way to increase the intensity to actually improve cardiometabolic health in the kids. So our next steps, honestly, that we're working on, I just submitted a grant in May that was looking at this. It was scored very well at NIH. It's not going to be funded, but we got a lot of enthusiasm and we're encouraged to resubmit. But one of the barriers that the families, it didn't matter if they were food insecure or not, that we commonly heard was, again, access issues to food, particularly fruit and vegetable intake. So what we are proposing is to test what's called a fruit and vegetable prescription, in which the healthcare providers provide a voucher to the families, and then the families can use this to purchase fruits and vegetables in a grocery store. And we had partnered with Food City to be able to do that. So we're hoping that we will be able to do that sometime in the future. But the idea with this type of program, and then combine that with our childhood obesity intervention, is that it could address issues of food insecurity, it could continue to enhance diet quality, and then ideally then we'll see greater improvements in health outcomes. So with that, I just want to acknowledge some of the funding agencies for some of the work that I discussed, and then I'll open it up to questions and I'll stop sharing my screen.
And I think Amanda wants to say that we should probably all open our videos again, and if we want to unmute ourselves.
I would say open video and keep yourself muted unless you have a question. And it looks like we do have one question in the chat submitted by Dawn. It says, does virtual contact have similar impact to in-person contact?
You know, we actually do not know for children. So we don't know in family-based programs. We do know in adults, so the work that's been done with adults. So e-health is a commonly looked at strategy in research in healthcare. But in adults in the area of weight management, our initial programs that were done remotely, in which we were using the internet in different ways, were not as effective as our face-to-face programs. They usually got about half as much improvements in weight that our face-to-face programs have. But I can say, as technology has advanced, it does look like that our adult programs are beginning to catch up to our face-to-face programs in terms of their effectiveness. So for example, just to give you, to help you understand the change. So when I was a postdoc, which was, a few years ago, when I was a postdoc, I actually worked on an e-health trial. What we did at that time, there was nothing like this. There was no Zoom, so we would post on a discussion board intervention materials and ask individuals to read the materials. And then we would do synchronous chat sessions. So we couldn't see each other and everybody's typing to deliver the intervention. Very different than what we can do now, which now obviously we've got this technology. Apps can be incredibly helpful in terms of tracking information that the interventionist can get in real time and sort of see what's happening, which we also could not do before. We'd have to have people mail things into us. So it does look like that there's definitely is lots that can be done from a technology, from an e-health perspective. It just hasn't been really looked at with kids yet.
Anyone have any other questions?
Hollie, just kind of follow up, different deal. The whole business of healthcare providers being able to have somebody to digest research information and get it to them in some kind of format and timing that that helps them, that they can really grab the baton and run with it, you know, because they've got so many things they're trying to do. My now late wife's oncologist, you know, it was just a challenge, you know, particularly for people like that, of course in severe obesity, obviously, you know, death is an issue as well. And so that's what oncologists, of course, are fighting. And I really felt for the oncologist because he was trying to do as well as he could to stay current on research and on potential clinical trials and so forth. But, you know, he was busy, you know, all the time with, you know, with patients and treatments, and I mean, kind of 24/7 about blood and all kinds of stuff. So that seems like just a magnificent thing to have a process that can extract early indicators of success and feed it to them, but also have the sub parts about, but you got to have more contact in order for it to be effective, but you have to have the parents buy in, you know, but you know, those kinds of critical things so the provider can emphasize those when they're implementing.
Yes. Yes. Yeah, no, you're absolutely right. And I can say, you know, even to take it a step further, which thinking about my relationship with Cherokee Health Systems, one of the reasons why our relationship is so beneficial to both of us is that they know I go over to their sites and provide the health provider training so that it's even easier for them to understand how do you look at these guidelines and how do you use them? What does it mean? So if they have questions or if they don't understand something, I can bring my research hat and go, well, this is what it means, and this is how you would think about it. And so being able to have, and for me as a researcher to go, wow, I can see the research that I do or that others do and actually see it affecting, you know, practice and the health of people, which is, you know, why I got into what I did. I mean, it's just a really, really, really super nice relationship.
I have a question, if I may. I thank you for making it very clear how difficult it is to get meaningful information about what works. It's just so complicated. From a point of view of someone who is both a psychologist and a dietitian, highly trained in nutrition, what if I had a daughter or a granddaughter who was, or a grandson or a son who is overweight, what is most effective? Is it more exercise? Is it killing off the junk food? Is it just adding the good foods? Where can you, from your experience, what is the priority?
Yeah, I can tell you in the area of weight loss, and this is true for children and adults, and it's a message that many people don't like, it's the diet that's the most important thing. And it's just because of the amount of energy deficit. It's just easier to incur an energy deficit by reducing how much you consume as compared to trying to increase your physical activity to a level in which you're burned an additional like 500 calories per day, for example. So we know that the diet is actually the key component. Now, to be honest with you, which is the better message, like reduce problematic foods or increase healthier foods? We actually don't know. It does look like that you have to do both. So the research that we do see at this point in time looks like that if you just focus on increasing healthy foods, that people just add them to the diet. So rather than that pushing other things out of the diet, that it's just added. So the quality of the diet improves, which is good, but that's not what's needed for weight management. We have to focus on the energy component. And so that doesn't look like that would be the best strategy in general, just focusing on increasing healthy foods. On the other hand, if you just focus on what you need to decrease or what you should not be consuming, psychologically, that's harder for people because that's not a message that we like. And it feels confining, to be honest with you, to most people. So to have a message of, eat less of this to help with the energy balance component, but to eat more of this to help with the feeling about like, oh, here's something that I can do. Generally, people think that this is the best way, but we don't have really good empirical data on that.
Thank you.
We have a couple of questions in the chat. One is from Crispo. She asks if financial support is needed to allow clients to buy appropriate food, how can the behavioral changes be continued beyond the end of the study?
That's a super great question. So one of the issues that we, and I mean research as well as practitioners, need to do a better job of, if we are wanting to better understand how to address health disparities, is this issue of food access or quality food access for individuals. So right now, I mean, obviously we have food supplemental programs that are overseen by our government in terms of providing assistance to increase access of food and to increase access quality food. But those programs don't usually have a lot of support in terms of behavior change. And oftentimes the behavior change focused programs don't have the support of the federal programs. So ideally, what we can do is that we can begin to combine those two things and figure out how to integrate them. And honestly, that's what our latest grant is a first step. It honestly has not been looked at before, is how do you begin to integrate those? Now, our fruit and vegetable prescription program is not a federal-based program that would be supported by the funding. But it's the same concept of using more of a supplemental food program and then combining it with a health program. And then what does that look like and how does that work?
Thank you. We have one last question in chat and then we will wrap up. Michael Graham is asking, do you collect information on the family diet prior to the intervention? And what does that information reveal to you?
Yeah, so we generally collect information on dietary intake, usually in one of two ways. So one would be where we have families complete what's called a food record, and where for a certain number of days, they're actually tabulating, writing down, or using some type of technology, what's being consumed. The other way that we do is actually what are called 24-hour recalls, where we actually generally do them by phone and we contact the family and we ask them to think back to yesterday, and then they report what's been consumed. In research, so those are actually very standard dietitian tools that we use to assess the diet. In research with the 24-hour recalls, what we can also do is we will actually have families take pictures of what they're consuming. And then we can access the pictures while we're collecting the information self-report, and to help with the accuracy of reporting and making sure that we've got measurements and that food and drink are reported as consumed. So that's the way that we do it. And what do we find? We do find that the diets of families are generally of very low nutrient quality and very high in energy density. So we do not see healthy diets coming into the programs. We do generally see very, diets that have a lot of fast food and sugar sweetened beverages and cookies and candy, etc.
Thank you, Dr. Raynor. And thank you
Welcome.
everyone for joining us. Dr. Raynor, if you don't mind, would you put your contact information in the chat so that people, if they have further questions, could get in touch with you?
you.